compensation. We have three speakers, Dr. Cameron Barin, who is Assistant Professor Emeritus from the Department of Otolaryngology, the Ohio State University. And we have Dr. Michael Schubert, who's Associate Professor at Johns Hopkins University School of Medicine, and he's also a physical therapist. And then I'm Wendy Crumley-Welsh. I'm the Product Manager for the Balance Products at Otometrics. So just a couple of tips. All participants are muted to reduce background noise. It is possible to ask questions during the session using your question box. So that's over on the in the panel, the webinar panel, in your webinar menu bar, so you can type in questions and then we'll answer those at the end. All these questions will be collected during the session and will be answered at the end of the session. And in case of unanswered questions, we'll reply by email to you to answer your questions. If you experience any technical problems or need immediate support, please write a message directly to, and actually it's not Anders today, it's Peter Fisher. So you can write a message to him and he can help you out. So again, here's our three presenters, Dr. Barin, who will start us off, and then Dr. Schubert will come in after him, and then I will wrap it up at the end. So Dr. Barin, when you're ready.
Good morning, everyone. I hope you can see my screen. Well, actually, I should say hello, everyone, because I don't know what time zone you're in. We're time zone in the morning here, but some of you are as far as China, Singapore, and other places, so all of you, welcome. We're going to start with the topic of vestibular compensation. When a patient suffers unilateral vestibular loss, such as vestibular neuritis or Meniere's disease, which causes an imbalance in the output of the vestibular receptors, then these patients suffer a series of symptoms. Some of these symptoms are referred to as static symptoms because they're present when the head is still. These types of symptoms typically are characterized by vertigo, imbalance, unsteadiness, and a series of autonomic symptoms such as nausea, vomiting. These types of symptoms are commonly associated with the acute phase of the vestibular loss. But these patients also suffer from dynamic symptoms. These are the types of symptoms that are present when the head is moving. These type of symptoms are primarily represented by loss of visual acuity and images not being clear during the head movements. These types of symptoms are present all along, but usually the patient has more debilitating symptoms that are static symptoms to pay attention to these. So they become obvious a little bit later on after the onset of the lesion. As we know, in most patients, not all, but most patients, these symptoms usually become less intense over several days, and in most patients eventually disappear, even in patients who have a permanent loss of vestibular function. This type of recovery is due to a neurophysiological process that we refer to as vestibular compensation. In the next few slides, I am going to describe just the basic physiology of what happens during vestibular compensation. I am going to limit my presentation to the recovery of vestibular ocular reflex, but we know that this happens in vestibular spinal pathways as well. I'm also going to talk only about the permanent and complete loss. That is, again, just an assumption to make things easier. Obviously, recovery happens in cases of incomplete loss as well. So let's discuss how our vestibular system reacts before there's an abnormality, before there's a loss of vestibular function. This diagram that you're seeing here is a representation of the peripheral vestibular system, which consists of the labyrinth and the vestibular nerve. And you can see that the activity of the vestibular nerve from right and left is the same. And the information from the vestibular nerve goes into the vestibular nuclei. And again, the activity of the vestibular nuclei that are represented by the density of these dots, they are equal. So, and you can also see the numeric examples from this, that if you take one hair cell and if you look at the activity of this, it produces approximately 100 spikes per second from right and left. This type of a balance is represented or interpreted by the central nervous system as lack of motion, so therefore there's no extraneous eye movement. If we suddenly rotate to the left, momentarily you have increased neural firing from the direction that you're moving to. So in this example, as you can see, the area of the vestibular nuclei from the left side shows increased neural activity after the arrow that indicates the onset of the rotation, and you can see decrease of neural activity on the right side, which is represented by blue dots here after the onset of the rotation. Now, just a numerical example, I've assumed that this goes up, the neural firing goes up to 150 in the from the direction that you're moving to, and decreases to approximately 50 when you're moving away. Again, these numbers are hypothetical. They actually relate to exactly how fast your head is moving. This type of response generates nystagmus, as you know, with the slow phase of the nystagmus moving away from the direction of motion and the fast phases moving toward, so this generates left beating nystagmus. The purpose of that is to keep your eyes stationary on the target, so when your head moves to the left, your eyes would slowly move to the right. The intensity of this nystagmus, or the slow phase velocity of this nystagmus, is directly proportional to the head velocity. Now, if you have a sudden loss of vestibular function on one side, in this case we're talking about the right-sided lesion, again hypothetically, you suddenly see that there's a drop of neural activity after the arrow, which is the onset of the lesion, from the side of lesion. So no more neural activity in the vestibular nuclei of the right side. The neural activity in the left side remains at the level, previous level, 100 spikes per second. Now, we see that the central nervous system is observing the same asymmetry that it did for that hypothetical head motion. That is, you have difference of 100 spikes per second between right and left labyrinths. This now becomes interpreted the same way that it was for actual motion. So the perceived head motion behaves the same way, at least in the immediately after a lesion, and the patient generates nystagmus as if the head was rotating to the left with the same velocity. This is an interesting phenomena because the intensity of the spontaneous nystagmus here reflects patient's perceived head velocity. So as you see when we go through this compensation, the intensity of spontaneous nystagmus can tell you about the level of the patient's static symptom. At the onset, this is very high, and usually patient is quite symptomatic, but as the compensation takes place, this gets reduced. So initially, one of the characteristics of the vestibular responses in a normal individual is that the vestibular responses are usually changing constantly. There's no persistent asymmetry that usually you see in a patient with the loss of vestibular function. That persistence of neural activity, that persistent activates vestibular compensation mechanisms. Exactly where these compensation mechanisms are located We don't know. But in animal studies, it's been shown that if you destroy the cerebellar folliculus, the animals will fail to compensate. So it's somewhere in the cerebellum, most likely in the cerebellar folliculus area. So when a patient suffers from a vestibular abnormality, they go through steps before full recovery from this loss. I'm going to just in the next few slides just show you these steps and discuss what each step will do. Fluctuating lesions such as Meniere's disease, they do go through some form of compensation, but it generates distinct findings which will be different than what I am talking about right now. I'm not going to address them here, but if you have any questions, we'll be happy to address that during the question and answer session. So the first step, which happens within actually maybe minutes or hours following an onset of the lesion, is the cerebellar clamping stage. In the cerebellar clamping stage, basically the vestibular compensation mechanism, as the name suggests, they put a clamp on the neural activity in the vestibular nuclei of the damaged side and prevent these difference or the asymmetry from being transmitted up to the higher central nervous system centers. This clamping has been shown in animals that it does happen. If you cut the nerve in an animal shortly after onset of one lesion, usually these animals just become bilateral, they exhibit bilateral loss of function. On the other hand, if you wait a week or so, the animals will show a secondary loss of unilateral function, which can only be explained if this compensation is going through clamping and the stages that we'll talk about in a minute. The clamping stage essentially reduces the neural activity from the vestibular nuclei of the intact side, so the patient sees less asymmetry. As a result, the spontaneous nystagmus level decreases and the patient's symptoms become less. This stage is identical to when the patient is prescribed vestibular suppressants for control of the acute symptoms. That's exactly what vestibular suppressant does. It reduces neural activity at the brainstem and cerebellar level. In this case, we're not getting any neural activity from the damaged side, so it reduces the neural activity from the intact side. This also tells you that in order for these stages of compensation to take place, these patients need to be taken off the vestibular suppressants shortly after the acute symptoms are under control. If the patients remain on these medications, the remainder of these compensation steps may be delayed, or it may never take place fully. So after a few days after the onset of the lesion, generally that clamping will be reduced. So more neural activity starts showing up in the vestibular nuclei of the intact side. Interestingly, neural activity starts showing up in the vestibular nuclei of the damaged side. Of course, we are assuming that we have a permanent loss, and it's not possible for this neural activity to be coming from the damaged side. So where is it coming from? The most likely origin of this is that it's through the commissural connections between the vestibular nuclei of the intact and damaged side. This stage, still there's an asymmetry, but the asymmetry is reduced. The vestibular or the spontaneous nystagmus is not as bad as it was at the stage, at the acute stage. Still there's spontaneous nystagmus. Patient's still somewhat symptomatic, but these are moderate levels of symptoms compared to what they had at the onset. So if you wait maybe a few more days, maybe a week or so, maybe 2 weeks, and this depends on changes from one person to another person. It depends on the age, activity, and many other factors. You will get to a point where the neural activity to the intact side is restored to its baseline level, the clamping is removed, and the neural activity on the damaged sides have come up to this level of the pre-lesion level at the vestibular nuclei site. Now at this time, basically that asymmetry has disappeared, the spontaneous nystagmus has become minimal, and this patient does not have symptoms as long as the head is still. This stage of compensation is called static compensation, and it is one of the milestones of recovery from vestibular abnormalities. Static compensation the spontaneous nystagmus level determines this static compensation. Generally, though, in most patients, we don't ever get to a complete resolution of spontaneous nystagmus. The reason for that is as the patient is compensating, at some point in time, the asymmetry drops below the level that's sensed by the central nervous system as motion. That's like the threshold of the vestibular responses. Once you get below that, because the patient is not experiencing motion, then they don't compensate anymore. There's no need for compensation. So in most individuals, even people who have people who are not symptomatic, you get a low level of nystagmus, maybe 2 or 3 degrees, and it never, in the absence of fixation, and it never goes away. Static compensation is most effective if your lesion is stable. Unfortunately, in lesions such as Meniere's disease, where the vestibular activities are fluctuating, it's much more difficult for the central nervous system to compensate. Again, that's something that we'll discuss maybe in the question and answer session, but generally, as you know, Meniere's patients are not as they're usually more symptomatic. They have different types of symptoms, and over time they become more concerned and more bothered by their symptoms than somebody who has a permanent loss of vestibular function. Now, what I just described here does not mean that this patient is fully recovered. There's one other step that's required before the patient becomes symptom-free, and that's the dynamic compensation. If that same patient that we have discussed up to this point moves the head exactly the same way they moved before the lesion that we described before, in this case, the neural activity from the damaged side will increase to 150 spikes per second, but the neural activity from the from the intact side increases to 150, but from the damaged side there is no change because it's no longer tied to the movement. So the asymmetry that's caused is half as much as it was caused before the lesion. So this is interpreted by the central nervous system as half as much of a head motion as the patient's head is actually moving. So that means the images are now not stationary on the retina. The images are moving only, or the eyes are moving only half as fast as they should be moving. The consequence of this is that the images are not remaining stationary, and the key element that determines this dynamic compensation, and maybe Dr. Schubert will be addressing this, is retinal slip. Retinal slip will be present, and that means the patient still symptomatic when the head is moving. Many of these patients describe symptoms that, for example, when they are in the grocery store, they describe it as disorientation. They don't describe symptoms of vertigo, but more disorientation when they're moving their head. For example, they're trying to read the boxes or cans in the aisles, and when they're moving their head, the images are not moving as they expect, and that's what causes the symptom. Now, basically, this dynamic compensation requires recalibration of the neural pathways. The central nervous system now has to understand that not 100 spikes per second, but only 50 spikes per second represent the kind of head movement that they're experiencing now. And that recalibration usually takes a long time because it is, use an analogy of, imagine that you had a database that you had built during your childhood for all different types of neural firing patterns that described a certain type of head movement, and that database now no longer is correct, and you have to rebuild that. That neural database usually took a good 10, 12 years from birth until the maturation of the central pathways to be formed, and now suddenly that database is not useful, and you have to recalibrate that. Now, individuals who are young, active, may be able to do this on their own, but oftentimes these patients require some sort of vestibular rehabilitation or physical therapy if they're older and if they're not compensating on their own. So this is a very brief description of what happens in the vestibular ocular reflex. We're very happy that Dr. Schubert is joining us, and he's going to give you the real part of the lecture about especially the idea of how VHIT responses change after the onset of a lesion. I will hand over my presentation to Dr. Schubert. Thank you.
Thank you, Dr. Barin. So I'm glad to be here and to talk with you about vestibular rehabilitation a little bit, generally, sort of broad strokes about what vestibular rehabilitation is, as well as how we track compensation, particularly related to oculomotor and gaze instability, which, as Dr. Barin has outlined for us very well, that is a common symptom with graphical evidence that we can track in folks that have vestibular hypofunction. So vestibular rehabilitation generally is broken down into a couple of different types of exercises. The one that you're seeing on your screen, which is bolded, is what we're going to focus on today. There are unique exercises that have been designed based on some of the same studies that Dr. Barin has mentioned to improve gaze stability. Now, gaze stability refers to the eyes being stable in space. So it's the functional ability to see clearly during head rotation. Now, whether that head rotation is actively generated by the subject or passively generated, and or that occurs naturally when we're not thinking about it, such as walking or riding in a moving vehicle, the brain has the task, and the vestibular system have the task of keeping the eyeballs still so we can navigate through our environment. So specifically, we're going to talk a little bit about the gain of the vestibulo-ocular reflex, and these exercises are designed to improve the gain of the vestibulo-ocular reflex and to recruit alternate strategies, that is, compensatory saccades. Now, the gain of the vestibulo-ocular reflex, as most of you know, is a simple metric that is eye velocity divided by head velocity. So as Dr. Barin has mentioned, the vestibular system detects both head rotation as well as acceleration or linear motion of the head. The gain refers to eye and head velocity. So if I turn my head 100 degrees to the right, 100 degrees per second, sorry, to the right, a velocity measure, then my eyes should move 100 degrees per second to the left. And that difference between eye and head velocity, 100 divided by 100, should be 1. Now, ideally, that is the value that the gain of the vestibular reflex is, but in reality, that fluctuates, plus or minus roughly 15 to 20% about that. So it's normal to have a VOR gain, for example, of 0.85 or 0.9, and there are age-matched data on healthy controls that we're beginning to understand. So we'll talk mostly about gaze stability. Some of the other things that vestibular rehabilitation does is we develop exercises that are designed to reduce symptoms, which are generated by head motion. Of course, positional maneuvers to return any displaced otoconia. This is the very common benign paroxysmal positional vertigo diagnosis. We focus on fall risk reduction and gait and balance retraining. So most of the patients that present in our clinics complain about their balance, they complain about falling, and they feel dizzy. They don't really come up to us and say they have gaze instability. But gaze instability is one of the primary exercises that are important in vestibular rehabilitation. Again, we believe will help reduce these other symptoms that they more commonly complain of. So as Dr. Barin mentioned, there's two broad categories of compensation. Static compensation occurs spontaneously. The static compensation examples of that are perceived perception of what true vertical is. The ocular tilt reaction is a response that can happen in both folks that have peripheral vestibular damage, that is the end organ itself or the nerve is damaged for some reason, and they will have their eye position is misaligned relative to one or the other, so they can have one eye turned in a direction that's known as roll relative to the other eye. Spontaneous nystagmus, again, as Dr. Barin has mentioned, is this reflexive asymmetry between the nuclei and the vestibular brainstem that generates nystagmus or eye rotation. And then again, their subjective visual vertical, which is what their perception of true vertical is, that can be off. Those all occur spontaneously. They will recover spontaneously, particularly in those that have a peripheral cause for their vestibular hypofunction. It differs a little bit if it's a central cause, and by central, example, a stroke that affects the brainstem. Those folks will recover uniquely, but in peripheral vestibular hypofunction, these compensations occur spontaneously, irrespective of rehabilitation. However, dynamic compensation requires movement, as Dr. Barin has told us. In particular, we need people to move and do the very activities that they often avoid because they know that they look like they have imbalance or they feel dizzy when they do that. And some of those examples are we ask people to do gait and balance exercises. We start them on a walking program, and we have them do head rotation exercises. And dynamic visual acuity, many of you know, refers to a functional measure of gaze stability. And we know research has shown that we can improve dynamic visual acuity with these exercises. So dynamic visual acuity, again, individuals move their head from left to right as if shaking their head to say no. And there are both clinical and computerized versions. Essentially, they're asked to identify a letter during a head rotation. And that ability to see clearly during head rotation has been shown to improve with unique vestibular oculomotor exercises. So the point of this slide is just to impart to you that head rotation is critical for recovery. Now, some of the mechanisms of gaze stability that we're interested in are saccades. And a saccade, as you may know, is a rapid eye rotation that its purpose is to very quickly reorient the fovea to an object of interest. So if you're walking down the street, somebody hollers your name, you will quickly rotate your eyes, followed by a head rotation to look at the target. Well, in 1978, there was a study that showed that saccades can be recruited in the place of a deficient vestibular slow phase. And over the last 30, 40 years, there's been additional studies that have identified these saccades, and sort of they've been named different names. They're all essentially describing the same thing. And basically what happens is illustrated in this figure below. So if you look at the cursor here, you'll see a head rotation in this light blue that peaks roughly at about 180 degrees per second. This is the head rotation. Green is the vestibular, or the slow component eye velocity that Dr. Barin mentioned. So Normally what happens is the head rotates in one direction. This happens to be a leftward head rotation. The eye velocity normally moves in the opposite direction. That's normal vestibular reflex. In this example, the eye velocity trace has been inverted for ease of comparison, so we can quickly compare and see that the green trace, the peak of the green, is not nearly as high as the peak of the blue. This is illustrating a vestibular ocular reflex deficit. And what you'll see further is there are these black spikes in the trace. These are the compensatory saccades that are in the place of the deficient vestibular slow phase. Now the software very nicely colors the eye trace uniquely depending on the type of eye movement. Of course, the eye is doing all of these things together. So the head is moving to the left at this velocity. The eye is slowly moving to the right at a slower velocity. The brain recognizes that it's not moving fast enough, and it shoots at rapid saccades, these peaks, these spikes. So these type of saccades represent a compensatory strategy that the brain uses to keep the eyes stable during head rotation. Again, this is the same saccade that was described by Kasai and Z in '78. Michael Hamagi, who many of you are familiar with his work, is a neurologist in Sydney, Australia, and he coined this term overt and covert saccades to reference whether they are visible to the naked eye or not. So saccades that occur during the head rotation, so basically the head is accelerating here, it reaches a peak velocity, then it decelerates, and it comes to zero right about here, sorry about that, where my cursor is. So there's a nice delineation here, kind of where this valley is, between those saccades that would not be visible during the clinical head impulse test versus those saccades which are here, which would be visible once you stop the head rotation and are watching the eyes. So an overt saccade is visible to the naked eye and occurs after the head rotation is stopped. A covert saccade are not visible during the clinical head impulse test as they occur during the head rotation. Well, the development of these video head impulse test devices, we can now graphically see this. And it's advanced our ability to measure gaze stability in greater numbers of individuals. So many of you are familiar with this plot, but just to familiarize you, this again is a leftward head impulse test wearing the video head impulse test equipment from Geonotometrics. This is a rightward clinical head impulse test. You can see that the head is moving to the right about the same velocity. This is a passively implied head rotation. The eye is moving in real world in the opposite direction, but we've inverted the trace. And you can see that there is some reduction. The VOR gain, that is this slow eye velocity, is not quite what it is for the head direction towards the right. That's normal due to these contralateral fibers that are now affected from the ipsilesional side, but it's much different. This is a summary slot. This is the mean in X is the mean of the gain for rightward in red head rotations and leftward in blue head rotations. You can see that both of the X's are in this gray area and they are below, not within these age-matched control line plots. So we would like to see both red and green X's between the line plots here. So I'm going to talk a little bit more about these compensatory saccades. We've measured them. Again, we had this exceptional equipment. We had to put contact lenses in people's eyes, and we still do that. It's the most precise way to measure eye movement, but you can imagine it's not done clinically, and the sample sizes are very low. But based on those studies and studies that of these compensatory saccades, again, these are the covert. These are the saccades that are occurring during the head rotation, which you will not be able to see unless you record the eye movement. They reduce gaze position error. Now, gaze position error is simply the difference between target and eye after the head is moved. So if the right vestibular system does not work and we turn the head to the right, the vestibulocular reflex will not keep the eyes stable on the target. After we stop the head rotation, the eye will be off target, and that difference between where the eye is after the head has stopped moving and where the target is gaze position error. And there's been numerous studies going back to 1988 that have shown that the presence of these saccades has a functional meaning. They are functionally relevant to get the eye closer to where it should be. The latencies at which these things occur have been reported to be as low as 40 milliseconds. Now that is really phenomenal. Latency, again, refers to the onset of the compensatory saccade relative to the onset of the head rotation. So it's the difference between the two. The normal latency of the vestibulocular reflex is about 6 to 10 milliseconds. So the brain generating these saccades does not do as good a job as the nerve, but 40 milliseconds has been reported in the literature. Most of them occur later, but they do occur in some folks earlier. The saccades have been shown to improve dynamic visual acuity. That is, when we formally measure dynamic visual acuity, so folks are wearing a headband that has a rate sensor attached.
Okay, so what we're going to do is we're going to move ahead and hope we can get Michael back online. I'm going to present my section, and then hopefully we can get Michael back online, and he can finish up his. Okay, so can everybody see my slide and hear me okay? Perfect. Okay, so we're going to just jump ahead real quick and talk about the ICS impulse, and hopefully we get Michael back online and he can finish up the interesting information that he had to present. So the ICS impulse, you can use the ICS impulse to monitor changes in patient response. All test sessions are saved for that particular patient, so if you test them, they come in, they're acute, or they come into your clinic and they still have symptoms, you have those test results, and then you can continue monitoring them, and all those test sessions will be saved under that particular patient, so you can review them afterwards. You can also provide combined reporting, so you can have multiple test sessions and multiple tests in one report as well. So just real quick, when you go into a patient, you go into patient list. So this is assuming that you've already seen them once. So they came in, they had symptoms, you diagnosed them, and now they're going on for rehab or treatment. And then when you access that patient, you would go under patient list and you would choose that patient from your patient list to make sure that all their data is stored together. Now, if you have a huge list of patients in your database, one easy thing to do is just search. So at the very top of the patient list, under last name, first name, patient ID, whatever, you can type in the first name, for example, or the last name, and then it'll pull up anybody with that first or last name. So it helps you be able to find that person quickly. Oops. Okay, and then when you're navigating through the tests, so now I pulled up this patient, and if you look here for the video head impulse test, there is a test tab, and under that test tab you would have all the tests that were performed for that patient. So if you look here in the lateral, you can see there was one performed on August 6, 2012 and one in May 16, 2012. So you go to your test tab and it's going to list all the tests for that patient. And then just another example, this is actually under skew deviation. There's a test tab, and then if there was multiple tests, they would be listed there. So for each type of test, the test list is provided for you. So then you can review data from when they had symptoms and as they're improving. And this just shows you again the test tab as well. So the top one is showing you gaze and spontaneous, and the bottom one shows you the lateral V-hit. So now let's talk about how to monitor changes with these patients. So this is the oculomotor module that's provided or that can be purchased with the ICS Impulse. And the three things we're going to talk about is spontaneous, gaze, and skew deviation. So this is an example of a patient. This patient actually had vestibular neuritis. This comes from one of our colleagues in Spain. And this is day one. So the spontaneous sitting, so the patient's sitting with vision denied, they had 7 degrees left beating for horizontal and 5 degrees, sorry, for the horizontal trace, which is the red trace up here, and 5 degrees down beating for the vertical trace. And you can see these are the traces here, and then here is your slow phase velocity graph for the horizontal trace, and the purple is the vertical trace. By day 3, in spontaneous sitting with vision denied, the patient had no nystagmus. So this is an example of vestibular neuritis where the spontaneous nystagmus recovered, which both Dr. Barin and Dr. Schubert had been talking about, that this is a static symptom. This is actually an example from a colleague in the U.S. This patient had Wallenberg syndrome. And so this patient came into the emergency room, and this is their gaze center. This is day 1, sitting with vision. There was 9 degrees of left beating nystagmus and 36 degrees of up beating nystagmus. So this is a central pathology. So again, the red trace is the horizontal, the purple trace is the vertical, and down here is the slow phase velocity graph. Red horizontal, purple is vertical. By day 3, the gaze center sitting with vision was 5 degrees left beating, 7 degrees up beating. And by day 7, we had no nystagmus in the horizontal trace and 3 degrees of nystagmus up beating in the vertical trace. So after 7 days, you can see their symptoms were improving. This is that same patient that had Wallenberg's. Day 1 and day 3 were basically the same for skew deviation, but when the eye is covered, there is a 4-degree horizontal rightward eye shift, or right hypotropia, and a 6.8-degree vertical downward eye shift. So here you see the horizontal trace again is in red, vertical trace is in purple, and what you see down here is the eye right here, that's eye open or uncovered, and then as the eye is covered, then the eye shifts down. So when the eye is uncovered, the eye goes back up. When the eye is covered, the eye shifts down. Then by day 7, there was only a 0.8-degree horizontal eye shift and a 3.2-degree vertical eye shift. So even the skew deviation was improving by day 7 as well. So that's the oculomotor information for spontaneous gaze and skew deviation. And now we have, we're going to talk about the video head impulse test, with which Dr. Schubert had been talking about. So monitoring the catch-up saccades using impulse. So again, we've talked about, Dr. Schubert talked about overt and covert saccades. Here's an example of overt saccades. So what we consider an overt saccade is any saccade that occurs after the head crosses 0. So, and Dr. Schubert mentioned this again in his presentation as well. But when that head trace, which is here in blue, comes back up to the 0 crossing, then anything after that is considered an overt saccade. So it's not happening during the head movement. And then down at the bottom, when you highlight that trace, you see the gain, the peak velocity, and then the saccades. So in this example, the highlighted trace has 2 saccades, and it will go up to as many as 3 saccades. But it gives you the latency of these saccades. So that's 204 milliseconds for the first saccade, 452 milliseconds for the second saccade. The next thing is covert. So this we consider a covert that occurs after 70 milliseconds and before the 0 crossing. So after 70 milliseconds, so right about here, and then before the head trace comes back up to 0, anything in here, so on this side here, is considered a covert saccade. So if you look again, that first saccade is at 4 milliseconds. That's a covert. It is then followed by an overt, just in the example, in the similar example that Dr. Schubert presented as well. So the second saccade is at 192 milliseconds. So that's an example. The first one is an example of covert. The second one's actually an overt. The other thing you can also monitor is the gain. And there's actually a separate graph that will let you put the gains from different test sessions together, and so you can see if there's any improvement in gain as well. So here's an example of early vestibular neuritis. This actually comes from our colleague in Spain. This is a right lateral. It exhibits scattered overt and covert catch-up saccades around 200 to 400 milliseconds. So over here, you can see that there is a lot of saccades, pretty much a broad range of saccades that are being presented. And the left lateral exhibits some overt saccades, which can occur on the contralational side, just like Dr. Schubert had shown in his example as well. And it's not uncommon to see a 10% or so reduction in the contralational VOR gain as a result of the disordered side not inhibiting. So this is the same patient, and this was later on. The right lateral exhibits gathered. So now let me go back a slide. See how these saccades are scattered across different milliseconds? And then later on, they start to actually cluster. And so you see the covert saccades here and the overt saccades here, which Dr. Schubert also talked about. And so these are occurring around 90 milliseconds and about 140 milliseconds here. Still have a little bit of disorder in the contralational side, but you can see that that gain is starting to come up on that contralational side. It's fairly similar. But so you'll see that they're not as scattered as the person starts to compensate, and you'll get a little more of this clustering over time in some patients. And so just so you know, Dr. Schubert's internet did go down, and so he is back up, and we will continue with him as soon as I am done. The other nice thing is the combined reporting. And so you can then choose, if you want to show data from the first time they came in to the second time and show improvement, you can include all of these test sessions in your report. So you would go to, this is an example of head impulse, and then you would choose to include both of those laterals in the report if there was change. So I'm going to have Peter transition back to Dr. Schubert so he can finish up where he ended.
So thank you, Wendy. I apologize. It looks like our internet went out and was lost for quite some time. So I've just two more slides to show you. We're back at the slide that I believe we were on when we lost. We've studied the effect of vestibular rehabilitation on these saccades. And what we've shown is that, as Wendy has just described to you, they change as folks improve. So we believe that the covert and the overt saccades are markers for recovery of gaze stability, and markers that we will begin to be able to use to probably predict and or identify that people have made good recovery with rehabilitation. So we've noticed that their velocity has changed overall changes by about 60 degrees per second. Their amplitude has changed about 2.5 degrees, and they increase in frequency in folks with unilateral vestibular hypofunction. So there's more of them. The brain is recruiting them more often, it looks like. This table is taken from a paper we did, and it's a relatively busy paper, but just to explain it briefly, the vestibular reflex, when there is a presence of these covert saccades, has a smaller amount of error. This is position in degrees relative to when the vestibular reflex does not have a covert saccade. So the eye is closer on target when there's a presence of a saccade than when it is not on target. We looked at that for both active and passive head rotations and found that to be the case in both unilaterals and folks with bilateral hypofunction. So we have begun to track these compensatory saccades when they start relative to the onset of a vestibular hypofunction, and we have some evidence to show that they start right away. And this is pre-op in a person that has a vestibular schwannoma, so a benign tumor growing on the 8th cranial nerve. These are head impulses towards the healthy side in this column. These are head impulses towards the affected side, and what you can see that even before surgery, there are the presence of these saccades. Now this trace is different from what you've seen. This is the head moving in red here, about 200 degrees per second. This is the eye moving in the opposite direction, and these are the spikes. All right, in the slides that we've shown you before, this blue trace has been inverted. But the only thing to show you here, if you look at this dotted line, you can see that it's moving towards your left. It's becoming earlier. So as folks over time are recovering from their surgery, this is a surgery to remove the tumor, and they end up cutting the nerve. And sometimes there's variable amounts of nerve being cut. It depends on the tumor and the size and the surgeon's preference. But you can see that as you drop down here on the slide, there's a progression towards the left. The latency of the saccades are reducing. So the closer we can get those saccades to the peak head velocity, we believe the better gaze stability will be. And then finally, for my talk, this is the final slide. This is a summary of what Wendy already showed you. This is a pre-compensation slide showing head impulses to the left, head impulses to the right. We can see that the gain, the vestibular slow component, matches pretty well the head rotation component. For leftward rotations, for rightward rotations, we see that there's this green slow phase that's very weak. There's a big gap difference between the peak of the eye and the peak of the head, and we have these compensatory saccades. They are a mixture here of overt and covert, because some of them, this one in particular, is occurring during the head rotation, but many of them are occurring after. As people compensate, though, we see that there is this less variability, as Wendy said, a gathering. And so what we're seeing is that they're sort of roughly dividing into two brief categories, early and then later saccades, and there's less variability. So we think that's probably a marker of compensation. So that's the end of my talk. Wendy, I'll hand it back to you for some questions and answers that some of the attendees may have.
Can you bring up my slide again? Okay, so just in summary, we've talked about that unilateral abnormalities cause both static and dynamic symptoms. Vestibular compensation takes place in 4 steps, with cerebellar clamping, gradual appearance of neural activity, complete restoration, and then reprogramming. We also mentioned that static compensation occurs spontaneously, and dynamic compensation needs to occur with movement. And then compensatory saccades reduce gaze position error, improve dynamic visual acuity, and are modifiable post-vestibular rehab. So we have several questions here. And let me go to our questions list. So the first question was, I've seen cases of vestibular neuritis who didn't compensate at all based on the hit result, even at 6 months after the crisis. Do you have an explanation for these situations? And she's basing the compensation on patient symptoms and VOR gain.
So I can take a stab at that. VOR gain is relatively, does not change very much with compensation. So it's one of the things that we like to document and look at change, and there's plenty of evidence to show that in some people it does. But that gain change is difficult to manifest. We think we're going to require some unique types of training paradigms to actually change the VOR gain. So it's not uncommon that gain does not always improve with compensation. It's important to determine from your patient, what were they doing? Were they active? Are they doing the right type of gaze stability exercises that we believe do drive that change? And then finally, folks adapt and compensate differently. We believe that there are some folks who will use compensatory saccades more often, and that'll be their primary mode of gaze stability. Others will have VOR gain change. Others will do things like close their eyes when they turn their head and adopt some other type of strategy as far as their improvement in compensation.
Okay, next question is cognition is an important part of the compensation. Is it possible to boost this in other ways to just reduce anxiety and tiredness?
So to boost cognition in order to improve sort of, yeah, rehab and compensation, there's a lot of new evidence coming out that cognition and spatial navigation and alertness is important and is affected negatively with vestibular hypofunction. We are actively investigating some of that. We don't really know yet. You're correct in that cognition and alertness is very important to measure the vestibular system. It's always a standard of doing vestibular function testing that we have to keep people awake and alert. But the relative roles of how it affects oculomotor recovery are relatively unknown still.
If I may add something to Michael's comment, this is Cameron Barin. I think, as Michael said, cognition is an important factor, but so is the anxiety, and I think we know that the anxiety level in the patient enhances the perception of the asymmetries. The studies that have been done in the University of Pittsburgh suggest that the centers that are related to the vestibular activities and the anxiety centers are very close to each other, and they may actually interact with each other. So yes, that is true. If we can reduce the patient's anxiety levels, these types of compensation may occur more effectively or more robustly. And I don't know if Michael has any addition to that or not.
No, that's spot on. Thank you.
So the next question is, how should we interpret a case of low gain in one side with absent corrective saccades?
Dr. Barin, you want to comment on that?
Well, there are two things that we could look for. One is that obviously some sort of artifact, so it might be that the low gain is not really low gain, calibration or some other factor. The other thing that we have to look for, any type of oculomotor abnormality that may affect the saccade velocities. So for example, a patient who has internuclear ophthalmoplegia, if you look at their VHIT results, you may be able to see the saccades when they're going in one direction, but you may not be able to see the saccades in the opposite direction, not because they do not have it, but because the saccade velocities are so low that they're intermixed with the VOR activity. So those are the two that I can think of right now. There may be others, and again, I'll just see if Michael has any addition to that.
I would just add that, again, what you said, Dr. Barin, which is you need to do an oculomotor exam, at least a clinical exam, if not a formal laboratory exam, to make sure the saccade system's working. Because these saccades are generated from a part of the brainstem that the traditional and the more traditional saccades are generated from. If they have a normal oculomotor function and they don't have any compensatory saccades, then I tend to view that as not compensated. Now, we're beginning to learn more about that, so these studies are being done right now, but I think we will be able to say that with more confidence once those studies and larger sample sizes have been completed, that folks should be able to recruit and use a compensatory saccade. If not, there's probably something that's been going on either in their training or what they're not exposing themselves to the necessary error signal to drive the change, or there's something wrong with their central nervous system.
Okay, the next question is, would covert saccades improve gain of VOR and VHIT?
They should not. They're separate oculomotor systems from separate parts of the brain stem, and we We consider them uniquely. What they do, the combined response of a vestibular gain that's weak plus a compensatory saccade is to reduce gaze position error. But we separate them out as far as their relative contribution. So we want the VOR gain to be as high as possible, and then when it's still not high enough and it's deficient, we then want a compensatory saccade to occur as early as possible so that together they work to reduce gaze position error, to keep the eye on the intended target relative to a head rotation. Dr. Barin?
Yes, of course, Dr. Schubert's explanation is perfect. There is, I think, some of the questions that are coming up about VOR gain. My assumption is they're related to earlier studies where we have looked at the rotation chair results and we've looked at the VOR gains at low frequencies, and it's been shown that the VOR gain actually improves. Now, there might be something to it, and that would be different than the VHIT VOR gain, which we are dealing with the high frequency and high velocity VOR gain. In low frequencies, I have to caution that what we have seen as increase in low frequency VOR gain may not be related to actually increase in the VOR gain, but how we measure the VOR gain in rotation chair, for example. In rotation chair, we essentially fit a sinusoid through the eye movements and then compare it with the head motion. In the early stages of the lesion, actually our VOR eye movements are clipped on one side. They don't look like a sinusoid until we get more and more into the compensation stages. So if we just fit a sinusoid through that, it will not be a perfect fit. And as you measure the VOR gain by this asymmetrical sinusoid, you may be actually underestimating the VOR gain when you're moving toward the intact side. So in that case, yes, we have seen, and I think there's some evidence in the literature that VOR gaining increases with the during the compensation, but exactly what that means and how it correlates with the VOR gain in the high frequency VOR testing, there might be a difference. So I would really like to hear Dr. Schubert's follow-up to that too.
Well, I agree. I mean, I don't think I have much more to add. I mean, there's a lot that we don't understand about the differences in compensatory strategies across different velocities, as well as the different type of head rotation, so active versus passive, and what strategies the person will be able to recruit.
So we're running a little bit over time, but there's some interesting questions here, so we're going to continue for just a few more minutes. The next question is, what happens for corrective saccades in fluctuant vestibular disorders and when recovery rather than compensation happens? Dr. Barin, you want to answer that?
Yeah, Dr. Barin.
Well, actually, I think if you let me, I would just quickly talk about the differences we see in the fluctuating lesions as far as compensation. Then Dr. Schubert can take the question, the exact question of what happens in cases of, like, for example, Meniere's. Well, when you have a fluctuating lesion, the compensation basically gets interrupted in the middle. So, for example, a patient with Meniere's disease will go through the clamping stage, but as we know what happens, as we at least theorize what happens with the Meniere's disease, the function returns. In other words, the membrane heals after Meniere's attack, and at least in the early stages of the Meniere's, most of the function returns to the labyrinth. At that stage, if you have clamping on the side of the intact side and the function suddenly returns to the Meniere's ear, now you have an asymmetry that's opposite of what it was before. And these patients oftentimes actually have nystagmus that beats the opposite direction of what you might expect. That's called a recovery nystagmus. So what happens in this case, actually this compensation process seems to be extending the patient's symptoms because they go through a secondary asymmetry. Whereas if they had no compensation at all, they would just recover quickly. As soon as the function returns to the damaged site, they have symmetrical responses and everything would recover. So if the frequency of the attacks in fluctuating lesions is if it's frequent, sometimes the compensation mechanism learns that you are extending the symptoms, so it becomes less and less effective over time. So compensation mechanisms in patients with Meniere's probably is not as effective as people with the complete loss of function, and that's why one of the general management strategies for patients with Meniere's disease is that, well, destroy the site of Meniere's with labyrinthectomy in the old days, or vestibular nerve section later on, or with gentamicin therapy now. So that causes the same type of permanent loss where you can then compensate. So and right now there is a somewhat of a discrepancy in findings with Meniere's patients. What happens in VHIT? There have been several case reports of patients who have documented Meniere's disease. They have loss of caloric function, yet you don't see any abnormalities in VHIT. There are a number of theories on that, and all of them sound plausible. One, for example, being Meniere's is a low frequency loss versus VHIT measuring high frequency. The other one is the effect that the enlargement of the membrane causes a different type of caloric response where you get whirlpool effect in the endolymph, and you get the bending of the cupula in the caloric test, but you don't get the same thing because the hair cells are intact in the VHIT. Now, again, most of these are theories, and like most everything with Meniere's disease, these are complicated, and we still don't know the exact answer. So I will just turn it over to Michael for any other explanation that he has.
Well, that's I would agree completely with that. That's a beautiful explanation, and I would also expect that it would be rare that if you have the presence, if you document, if VHIT is used and you document the presence of these unique saccades, that they're probably not going to then go away. They will change. There's evidence that healthy individuals of age have these. So we think that the value of identifying these compensatory saccades is going to be in addition to identifying a low gain of the vestibular reflex. That is, they are present for a reason. A head rotation can be measured as a position change or as a velocity change, and those two different stimuli, whether the head changes position from start to stop or the head moves in a velocity from beginning to end, those are unique stimuli that recruit unique oculomotor strategies. So I guess the point is that just because a person's head moves to the right doesn't mean the brain will not get multiple signals that might recruit the presence of a saccade or not. And so it is complicated, as you mentioned, Dr. Barin. The other thing I would add is we've had the fortune of a couple of times catching a person with vestibular neuritis who had some natural recovery. That is, their caloric improved when we repeated the test, and their head impulse test gains improved. The saccades went down in frequency also. They were still present, but when the gain went up, we saw that the frequency of the saccades went down. So again, they were still there, but they are modifiable.
I think I want to make a comment. I think that's very interesting. I was at a conference presenting our equipment, and someone came up and asked me to test them. They had had vestibular neuritis in the past. They were completely asymptomatic, obviously, at this conference, but they still continued to have covert catch-up saccades in the VHIT.
That's right. That's right, and I think the brain will, they won't know any difference, but the gain relatively is relatively stable. It usually doesn't change very much. So the brain has to use some strategy to keep the eyes still, and so they will, function very well, as Dr. Barin and you both sort of commented earlier, that they make this great recovery. But if you record their eyes, you can see evidence for it. Now, if you do the clinical head impulse test, you might not even see it. It might be a completely normal clinical exam.
So two more questions. One is VOR gain is 1 plus or minus 15 to 20%. The examples shown demonstrated a definite difference between the head and eye velocities. What would you consider at normal difference on the V-hit?
Well, I think this is a better question for Dr. Barin, but there is just published a paper in the Frontiers of Neurology looking at norms of V-hit gain across decade of age, and I think Dr. Barin probably can speak closer to that. But we now know what age-matched controls are based on decade. For years, head impulse gains were based on search coil testing, and that's where the roughly plus or minus 20% comes from. So that means that a VOR gain roughly that's below 0.8, so a velocity that's 79 degrees per second relative to a head velocity of 100, for example, would be abnormal. But we're more we're more sophisticated now, and we're able to really know what age-matched gains are. So, Dr. Barin?
I agree with you completely. I think the fact is that the VOR of 1, exactly 1, is really hardly ever achieved in normal individuals, like most everything else. So measurement errors, and then just we know, for example, VOR in the dark is much less than 1, and just normal fluctuation with age. I think we were just the norms are emerging, and the studies that you cited, I think there are good guides that plus minus 20 is still fairly good estimate of the if you just want to talk about general terms, but obviously we have much better now age-based norms for these.
And just to comment on that, so regarding if you're using ICS Impulse, you do need to have the USB goggle, not the FireWire goggle, but there is the software version that came out this summer, 3.0, which will give you the age normative gain plots. You saw that on Dr. Schubert's, where it showed these lines in red and blue for the age norms.
Yeah,
so that is available.
Really useful in the clinic. It shows spot on where you get great. It's a great opportunity to educate the patient as to where they currently are and where the healthy controls are. It's very nice.
So last question is corrective or compensatory saccades a sign of severe vestibular loss or a complete vestibular loss, and how V-hit results compare to calorics?
Go ahead, Dr. Barin.
I'm sorry, can you repeat the question? I missed the question. My internet cut off.
Okay, so it's twofold. It's one is corrective or compensatory saccades a sign of severe vestibular loss or complete vestibular loss, and then how do V-hit results compare to calorics?
Yeah, I don't think we know the answer to that. V-hit really does not quantify the degree of loss. So even if a patient has a complete loss of function on one side, they still, because of the presence of inhibitory response from the other side, they still generate some VOR. Obviously, the VOR eye movements are not as large as the head movement. So the VOR gain that we have currently in V-hit, it really does not reflect the degree of loss like the caloric testing does. Obviously, the more severe types of loss will generate catch-up saccades at lower head velocities, and the less severe ones would require higher head velocities to see them. but otherwise the direct correspondence, I don't think we know that yet. And again, Michael can comment on this since he's seen many more patients than I have in this case.
Well, so that's right. I think the way to think of your vestibular function is analogous to an audiogram. When you have an audiogram or a hearing test, they test at different frequencies of hearing. The vestibular system functions at different frequencies of head movement. Its job is to really detect faster velocity head rotations, but it also functions at the lower velocities. So as it was mentioned, the caloric tends to measure the system at a lower frequency response versus the VHET measuring it as at a higher frequency response. So it's very perfectly possible that we will identify that there are unique pathologies that uniquely affect different frequencies of head rotation. So people might be able to detect slow head rotations but not fast, for example. The presence of a corrective saccade or a compensatory saccade means the eye position is off of target and the brain needed to get it back on target. Now, whether that's due to a vestibular problem or some other problem, it can vary. But generally, the presence of these compensatory saccades does suggest that there's some need for assistance to the vestibular ocular reflex. And again, there are studies that are coming out showing healthy elderly, as an example, have a lot of these compensatory saccades, even though their VOR gain by typical standards is determined to be normal. But again, our confidence in being able to say that you've had a vestibular assault due to the presence of a compensatory saccade when gains are normal, we still are uncertain of that. But yes, if they have a saccade, that does suggest that their eye position needed help to maintain stability.
Okay, one last comment. That you can go to icsimpulse.com. If you click on cases and research, there's a lot of good information there. And about kind of midway down, there is the article that Dr. Schubert referenced to regarding the compensatory saccades and the deafferentation with the patient with a acoustic neuroma. So when you read the text, at the very last word it says click here. If you click here, it'll browse to the abstract and you can download that article. But there's a lot of good information in there. Also odometrics.com and headimpulse.com. So headimpulse.com is the research site. icsimpulse.com has a lot of good information on there as well. And then odometrics.com is our company site where you can learn about products. So I want to thank everybody for attending, especially thank Dr. Barin and Dr. Schubert for presenting, and it's just been a great webinar. We really appreciate it.
Absolutely. It's fun. It's an honor to be here.
Thank you very much. That was great.